all good to go. Dr. Westphal.
Good afternoon to those that have joined us from different locales in the country, and I hope it's warm there, as warm as it is here in Florida, probably, which is the best in the nation, not to brag, but anyway, it's nice to be here today rather than in the snowy weather. I wanted to just take a moment to just talk a little bit about the two people who will be making presentations today. We're going to actually be talking about setting the stage, the methodology of quality management. And I can't think of anyone any better than a friend, long-term friend of the college, Yosef Dlugacz. He and I go back many years. We actually, before we started, couldn't actually remember how long we'd both been in college together. I've been in since 2005. But I want to just talk a little bit about Yosef and just kind of read a little bit of his bio. It's very lengthy, so I don't want to make it too long. It would take up most of the webinar. Dr. Dlugacz is an educator of international and national reputation with academic appointments at the Hofstra Northwell Healthcare School of Medicine, New York Medical College, Hofstra University, Baruch College, CUNY, and Beijing University, among others. He has been the author of several books, most recently, Introduction to Healthcare Quality, 2017. And I read the book and I would highly commend it for those of you that want to know more about quality, but also if you're interested in taking our ACMQ exam, it would be an excellent prep. Joining Dr. Yosef Dlugacz is Andrea Restifo. She's a nurse, and we have just recently with the college really made an effort to include nurses, and I'm very proud to have her presenting today. Andrea is an associate executive director for North Shore University Hospital, a tertiary care facility with 756 beds, part of Northwell Health. And I just want to take this moment to welcome both Yosef and Andrea. And without any further delay, let's get the webinar started. Yosef and Andrea, it's all yours. Thank you.
Thank you. Ready to roll. Thank you, Dan, for the introductions. We're really excited about setting the stage part 2, the methodology of quality management. Yosef and I really enjoy working together and giving you examples. Okay. Go ahead, play, DJ. DJ, is it playing?
So it looks like we're having an audio issue for, so she'll just give DJ a moment. He'll get that sorted.
Safety.
Here we go.
Thank you.
Thanks, everyone.
In that lecture, we'll be focusing on setting the stage for the methodology and quality management. It's a very important session. It really introduces the rationale for quality management process, the logic of intervention, and the most important, that there is a method. We're not looking at problems like in the past, but we're really focusing on PDSA, which is a Plan, Do, Check, Act, or Plan, Do, Study, Act. And then the second part will be on data. And then the third part, which is extremely important, will be on safety, which is really an outcome of the PDSA. Andrea will be talking now about the total quality management practices and application to healthcare.
The first class, we covered the philosophies that really led to quality management today. And in this class, we really wanted to focus on how the principles of total quality management apply to healthcare and in fact business. And when we look in the literature, we see the companies that create cars, that Xerox, that create cell phones, follow the total quality management practices. And really that has a people part of this, because you really need a sense of mutual trust, respect, and dignity. We need to look at what our customer expectations are, and we need to look at what ideas we have and to operationalize them by people in the front line that are close to processes. We have to make sure that we are have those people properly trained. As they have the right tools as workers, they will help with productivity and be engaged. And we can see that in the business models that labor relations does help that productivity, as well as have less defects in the product. The companies use statistical process control to make sure that if the process is controlled, and if they've changed the process, they know that that's documented to see what works, and then they can reset their control charts. When you look at the companies and apply it to quality, you can see that in order for us to be successful, we have to prioritize what we do.
So in any situation, if it's a healthcare industry or any other industry, you need to have a rationale for spending money, focusing on a particular issue or problem to solve it. So typically, you need to identify the scope of care that your organization provides, and then the dimension of it that can help you prioritize a particular key area. You can give it to each area, you can give it a score. It's really up to you. You can have 1 to 5, 1 to 6, 1 to 10. Then in terms of importance, you give it a number. And this number you can arrive by your own or with a group of people or even the CEO to figure out what to do first, what to do second, what to do third. It's important because you use resources. Those resources cost money, and you want to be cost efficient in terms of fixing a particular issue and improving in a particular process. So what you see here, we look at we give a characteristics in terms of patient safety, efficiency, conformity to the strategic planning, goals of leadership, improve the delivery of care, meet established benchmark, and satisfy regulatory compliance. So if you look at sepsis, you can say that all of the above, all of the issues that we just mentioned are important. So you can give all of them a 5. Is what you use as a scale, that 5 is the most important, 0 is not important. Or some people can say, well, in terms of patient safety, it is a 5, but in terms of the goals of leadership, it's not. They're not interested in focusing at this particular point on sepsis. They would like instead to focus on throughput. So this is why it's so important to have this format, this methodology, to have a discussion about a particular issue, because also you have to figure out how long it will take you to implement an improvement or to even arrive at the conclusion of the improvement. So this is a very good methodology. It's extremely important. And I recommend that to do it from the beginning, to implement the PDSA, and also every couple of months or every quarter to revisit the prioritization metrics to make sure that the goals still meet the CEO's goal and the top leadership within the organization. The next one is very important, which talks about the international standard for quality management principles. And the reason that it's so important focuses for the first time the customer leadership And this is where the prioritization matrix is derived from.
Yeah, and I think that when you look at the international standards, it helps really measure what the community wants. And as a leader, when you use the prioritization matrix and look at customer focus, it helps you resolve your own internal conflict of what to do first and then how to meet the regulatory expectations. So for the customer focus, when I look at the priority matrix, I think about mortality. The customer expects to survive their hospitalization, and how do we understand what their needs are? Are they informed of the procedure, the risk, the benefits? Do they understand their recovery? What's needed at home? Do they have the right resources for them to be empowered in their care? So the next one is leadership. And really that is getting that sense of purpose and unity among all stakeholders. And, using the prioritization matrix that Yosef just illustrated, that helps me go to my CEO and say, you know what, we do have to focus on sepsis because so many of our patients have it. And we don't want our patients not to do well. We want to identify it early. So we need a resource to help with rapid response and cardiac arrest, and fever, so we all can figure out how to best care for our patients.
I'd like to make a comment here because the customer and leadership are the foundation of performance improvement. In terms of the customer, the patient, of course, especially if you have a patient-centered environment, you need to focus on patients and families' need and expectation. And through either a complaint system or any other system that you have, like patient rounds, that Andrea will talk about it later on, you can come up with ideas where you need to. So this is extremely important. Leadership is important. They can give you direction. They may say, yes, let's focus or prioritize this particular issue because it affects a large number of patients. Yes, let's focus on this particular issue because we can improve on customer needs because our patient satisfaction is so low, the score. So in that way, they give us further direction in terms of prioritization.
Yeah. And then the next one, engagement of people. One of the things that I've seen across our health system is the engagement of frontline staff to be champions, to be that sepsis champion, to be the skincare champion, safety champion, that they are recognized for taking a course, getting certified, being the trainer for the staff, so they can really affect change and be engaged and recognize that as we give them a pin for that, give them recognition points. So it really has made a difference in moving and changing the people part of this. When I look at process approach, that really emphasizes efficiency and effectiveness, and that could be with hospital overcrowding. In the quality case, it could be really about timely resolution of patient grievances. We use process approach very frequently. We flow out a process. We see if there is opportunity to improve that process. And again, go back to engaging people close to that process. The continuous improvement is something that we do through our structure and through our rounding process, and really also through getting ideas from the frontline staff when we are rounding. So we look at what our data shows us. We look at the impact. We look at that prioritization metrics, and we embark on performance improvement projects that we can get a big bang and really look to make sure that we're improving our patient care and being patient-centered and improving our costs. So the other last two are evidence-based decision-making. And I have to say that I see now when the regulatory colleagues come in, they're looking for what is the clinical practice guideline you're using? What is the national evidence about stroke care that you're using? In particular, with TPA, or going to the interventional area on what's the best care for our stroke patients. So this is really important that you keep current with the evidence, as well as disseminate that evidence and put it into your standardized practices that you do, because that really helps reduce the variation. And lastly, relationship.
Before you go there, I want to make a point that because of the accessibility to different literature that is computerized, websites, and other sources of information and data, it's very easy now to bring the evidence very quickly to your database, to the patient, and everything else. So we are now can work with multiple data sets to explain the evidence, to explain the distance to the threshold, or even to explain how we deviate from expectation. So it's really an opportunity for a rich data that can be harvested and make the correct decision that is based on evidence and peer review.
Sure. And the last one here is relationship management, which can be between your suppliers and retailers, the vendors, but it can be between your relationship with education affiliations, with students, the relationship you have as a quality professional and your CEO, because really it's trying to understand the needs and to tailor the program and the customer expectations to meet them. What's really neat, and we noted here, the international standards for quality management, even though they're ISO standards, they are reflective in all the international and national accreditation programs. And how we took those principles, we took the at the time in 1999, the Institute of Medicine's guiding principles and applied them here at Northwell. And our goal is to be a high reliable organization. And in order for us to do that, we really make the patients first and safety always. This is from day one of orientation throughout Northwell here. You can see the investment in the quality structure that the system has made, and it is interdisciplinary, and it is effective. And we're going to, as we go on, we'll share some of our outcomes. As you know, the 6 aims of the Institute of Medicine is safe, effective, patient-centered, timely, efficient, and equitable care. And I think that right now we're really putting a lot of effort into equitable care, because really that is where we need to shift. We need to make sure we have an inventory of how we provide continuity of care, how we provide access to care, and really look at our demographics to make sure our services reflect our patients' needs. We always try to be efficient and timely, whether it's hospital crowding, getting patients ready for studies, discharge planning. These are things that really our care model here supports every day, 24/7. We are patient-centered because during COVID, in order for us to get through, we had to create a 7-day model. And it makes sense when you think about it, but it's not that easy because we're so used to, I work Monday through Friday. But if we're really, truly patient-centered, we're going to have interdisciplinary rounds on the weekend. We're going to have procedures offered on the weekends, echocardiograms offered on the weekends. And it's because we are trying to be patient-centered, also efficient, so we can really take care of the patients that we need to take care of. And then just, with effective care, I look again at sepsis because I see the volume of patients that have a touch of infection that can either be ruled in or ruled out for sepsis. And we really have to hardwire the interventions to be sure that we are meeting the 3-hour and the 6-hour bundles, and it's bigger than the emergency room. But at the end of the day, it's about the patient in the bed. It could be our family. And then lastly, safe. care, we go out and we have safety and patient experience rounds every week or every other week, depending on what's going on with the COVID and the environment. But really, we're looking to make sure that we're getting ideas from the frontline staff on how to make care safer and capture what they think may be that good catch that prevented harm. So we really are trying to bring these principles forward. We stress that when we do any quality investigation, that we want to make sure that if an individual did something, that we look at the system around them. We understand that individuals are going to make mistakes, and we have to prepare for them, and that's part of being high reliable. We know healthcare is a team-based sport, and we know that we have to reduce communication barriers to have a safer culture.
So really, in summary, you want to say that when patient come back to the hospital, new patient come to the hospital, they will experience in your high reliable organization those 6 aims.
Yes, absolutely.
This is the goal. This is really great. So it's not only important to improve the process, but also to establish an environment that people can experience consistent, positive environment that can improve care and produce good outcome.
Absolutely.
So from there, we are going to the methodology for improving organizational performance. It's not a methodology that was discovered in healthcare. In fact, it came from other industries, and it's based on statistics and method, especially the control chart. And the whole idea is that can we have enough variables and enough statistical data to make sure that we can improve a particular process. In the past, before the electronic medical record was much more difficult. We did it based on a select number of charts. Of course, it was based on a random selection, but it was hard because it had to be done by hand. And now with the electronic medical record, you can get quite a lot of information on a huge number of patients. So you can really rediscover performance improvement. So the whole concept of it is that one is that what you are trying to accomplish. What do you want to do with this information? I mean, do you want to illustrate to your manager or to the CEO that you're doing a good job? Or you want to meet the expectation of the need leadership in terms of making a particular process efficient? So this is something that has to be written and has to be addressed and discussed in a group, a multidisciplinary group, especially when the customer, the patient, or the family is involved. It's even better. Then the second question is, how will we know that the change is improvement? Some changes can be accidental, some changes can be natural. So you need to develop a good database and a good statistical analysis to illustrate that the intervention over time may change. So in this situation, you can compare data from before the intervention and then compare to after the intervention. Or you can have 2 groups of subject matters, one where you do the intervention, one where you don't do the intervention, and see what are the differences in terms of change. Then the third one is, what change can we make that will result in improvement? This is really critical. Now that you make the change, and statistically you can show that the delta, it has a value of 0.05, then what does it mean? In what did you make, what variables or indicators affected the change? So if you look at sepsis, you can say maybe the guidelines that we adhere to. On the other end, you can say, well, it's not only the guideline, it's also the people who are involved in the process. It can have an impact on change. So we need to really figure out what change took place, because this will help us to continue to improve and even improve further the whole process that we are planning to do. So this is a very important part, because performance improvement is a continuous, never stops. So we need to analyze the changes, positive or negative, to figure out how to improve all the changes. And what you have here is you need to plan for it. The planning is the planning is very important. It's a team approach. You need to discuss what is the goals, what you want to achieve, how to do it, who is going to do it, and also plan at that point for data, how data is going to be collected, or what kind of data already exists. Then, in terms of doing, we have to figure out how to carry out the plan, what kind of documentation we're going to add. This is very important. And then also, again, analyze data. In terms of the study, we're going to look at the results, we're going to look at what we are doing, and then try to figure out what kind of statistical analysis we want to do in terms of showing the changes. It could be that we look at cause and effect, it could be that we look at the control chart, and so on. In terms of act, is that looking at the results and trying to figure out what changes are to be made or made already, and then plan already for the next cycle of PDSA. So it's a continuous improvement. There is also rapid cycles where we look at a small process and we want to quick change. Change is very difficult to implement. You need to convince the team that the data that you have is accurate. You want to convince the team that the data is valid and reliable. And then you want to convince the team that if you do that, their lives will be even better too by doing it. Second part of the methodology, which is the key, and you can see it in the next slide, is the use of data. Cannot say enough about data. Data is, from the beginning, quality is the most important element. Without data, you don't have quality management. Without data, you only have meeting expectation of regulatory organization, but nothing else. So in order to be proactive, in order to start to focus on outcomes, in order to see how far you from the benchmark, from the evidence, you need data. So we need to figure out in the planning process already what kind of variables we want to include, what is our hypothesis, what kind of measures we are identified, how we prioritize, how do we collect the data, and what kind of a sample size we need, and also where are we going to get the data. So the sources of information is extremely important. Once we define the data with variables, we need to aggregate it into a database, and we have to start to analyze it in a way that the data is becoming meaningful, not only to us, quality, but also to the customer, to the leadership, to the physician and nurses. The data has to be ongoing. And once we establish a database, we have to continue this database. We can add more variables to make it more effective as we are learning about the changes. And then also, the bottom line is that when we talk to leadership, we have to illustrate how the organization utilizes the plan, do, check, act methodology for the performance improvement and how it works and why it should work. And in this way, leadership can make a decision. Yes, let's continue, let's invest in it, and let's do the right thing for the patient in a safe manner.
Yeah, I think from a hospital perspective, we want that methodology to be actionable so that we can really act on it and sustain the results. And when you share the methodology on a particular performance improvement effort, others will see how they can replicate it on something they're trying to do. So we really use our PICG, our Performance Improvement Coordinating Group, to share our hospital performance improvement initiatives so that others can adopt the methodology and also learn and not reinvent the wheel on different things they're trying to improve.
So this is very important because if we go to the next slide, we talk about one outcome, and the outcome is patient safety. And as mentioned here, in a high reliable organization, we can assure that the environment is so good that nobody gets hurt. And this is a very important goal. So we are doing it through methodologies like good catch or near miss. Can we elaborate later on? An example of safety culture is to prevent patient fall, to prevent patients from developing decubitus, to prevent patients from developing nosocomial pneumonias while they're in the ICU, to prevent morbidity in the operation like blood clots. So all of those variables need to be studied in such a way that it can prevent it from reoccurring, and as a result, establish new standards. Do you want to make a comment on that?
Yeah, I think that establishing a safety culture puts the patient in the middle of everything we do. And if you put the patient in the middle of this Joint Commission picture, I think we get the true safety culture. But I took this from the Joint Commission because to have the safety culture, you need robust performance improvement. You need to have leadership saying, yes, this is what we want. This is our strategy to better take care of our community, to build our brand, to build our services. And in order for it to do that, we need our frontline employees to know that if they see something, to say something, to report the good catches, to participate if we have a problem. We have a problem in patient identification. I want to make sure I'm asking the nurses at the bedside, I'm asking the transporters, I'm asking the procedure areas, what's going to make a difference. Let's talk about how we're communicating. How does it work? In our case, we found the transporters got distracted because they had to move beds out to get a patient out. And if we didn't hear that from them and go and observe the process, we would have just kept having the next error. So that frontline input, looking at the process and wanting to improve is key. If you don't have leadership and you don't act on what they're telling you, they will not trust you and they will not report. So establishing trust by engaging with the employees, understanding how they feel about safety. We take that yearly ARC survey for our employees to understand how they're feeling. Do they feel that we're punishing them for their mistakes? We want to encourage them to report. We want them to be able to go to their manager and say, I have a problem. We want to make sure they communicate amongst their unit and out of their unit together. And it's not telling, oh, the ED didn't call report on that patient today. It's looking at why. Did they need someone to manage the flow that day? What was going on in that ED, or was it not the right level of person that was involved? So really, we look at the why, and we really want to make sure that we are fostering the improved report trust relationship, and then not only will we get our safety culture, but we'll be more of a high reliable organization.
So to do that, Andrea, all of the employees need to be part of it. All of the employees in the organization need to know the PPSA, and all of the employees need to be understanding of the data, where we get the data, and how this affects our performance. And also they need to be able to learn from this data, from this analysis, and be able to develop new strategies at their own location.
Yeah, and I think that's a challenge for all organizations. Like, how do you get that data in an employee's hand to know that that's the data I got, I'm going to be working on? So, I think with our patient identification, we gave the data and said, there was near misses in one patient's being brought down for a procedure. So we were able to show them the data that it could happen. And with their input, we're able to change the process and then also make it more systematized, right? So if we had our ticket to ride, we really wanted to make sure that we had accountability to who was signing off and that it was used 100% of the time, not partial.
So all employees, regardless of their position within the organization, regardless of whether or not they are clinical and went to university, college degrees, they still need to understand basic information about data and how it's being used in quality.
Yeah, we're very fortunate that our health system gives it as part of orientation and as part of continuing education. And what we do here is if we have a risk management week or a safety week, we do additional classes here. And we involve those people that are on a service line or performing a different function. It's good to get your blood bank involved and your lab involved, and radiology, all these different services that support it's really, their input is invaluable. And when they understand it, it's even a bigger impact for the hospital. So,
and you know that because you supervise those ancillary departments in a very large organization, and you know, for a matter of fact, that people who touch the patient, so even don't touch the patient, but don't have any clinical background, understand the information, they are much more effective and efficient in the delivery of care.
sure, and I'll tell you a little secret. When we did our safety week, our transport team wore the shirts that said Plan, Do, Study, Act of that week. So people would say, what does that shirt mean? And then the transporters would tell the team members about Plan, Do, Study, Act. So, we try different things to get the message out and to have fun with it. We also had here one year, our medical staff gave an award for safety. And they said, hey, if a resident participates and a community member participates, that gives you points on your award. So it was recognition for a unit on their performance improvement. And then you showcase it across the hospital and everyone says, I'm doing that. I want to be part of that. So the following year of the submissions, we had many more. So, different things we're trying to do to promote the methodology, to recognize the team, and then always put our patient in the middle of what we do.
So this is really great. I think, Andrea, for the next presentation, we should have the t-shirts with PDS.
Sure.
Wearing it so we can illustrate to the audience that you really did it. But the next slide is very important. This is what do you want your outcome to be? And it's not that simple. I know that everyone will say, oh, that all our patients are happy. As you know, it doesn't work like this. Or you want to say that all of our clinicians will be satisfied with the work environment. This doesn't work like this. There's always variation. So how do you come to this concept of what do you want your outcome to be?
That's when I look at our hospital here, I want the outcome to be that we are meeting our strategic goals. And that part of that outcome is to improve reputation and to improve the care we deliver to the community in response to their needs, to be more sophisticated as a tertiary hospital, and to grow our services. And I think from a quality perspective, we have the most control over the communication and reputation bucket. So one of the outcomes that we want is external recognition of our programs that we do. So we're constantly looking to say, okay, we'll sign up for Joint Commission certification for palliative care, for comprehensive stroke, for ortho, hip, knee, spine, and really want to show the public, hey, we have that external validation and show our team that working together produces this great feeling of pride for our external survey. And it's involving our patients because we have company today and we want you to participate in that survey and get interviewed. So the outcome we want is patient-centered care, which is part of being in the community, and that external validation. And just last week, we did get validation of that by getting in the best hospitals U.S. News and World Report national ranking, which I think many of us want. We got named in the top 50 in 8 specialties. And then we were 5th in New York State and #1 on Long Island. So Long Island is where our health system is. So it also shows our public like we can provide that sophisticated care to the community.
I also want to make a point that you have a very important tool in your hospital because of the system. You have the PICG, where you communicate it and get communication feedback from members of the hospital team, which is very important. And you have lots of people coming and bringing ideas and concepts and looking at data. And then you have the other tool that you have is the medical board, like the executive committee, where you present this besides the rounds that you do the floor. So the thing that I'm mentioning, Andrea, is that what I would like the audience to understand that it's really hard work. It's not only about being the best, but to be the best. The process is very time consuming
And rigorous.
and we had to spend lots of time with the medical board to make sure that they understand what you're saying, and the same thing with the PICG. So those are really great tools that maybe one day we can explore further in our presentations.
Sure. And I think that, one of the key things we do here is have a very open door quality process that when you come into quality, whether it's a small thing or a big thing, we're going to help you and we're going to solve it together and we're going to learn from the experts. That might be the transplant surgeon or maybe the person that cleans the floor because they are close to a process. And we will always do the right thing for our patients. So really, I think that I thank you for your compliments, but quality's role in our organization is a key role, and I'm really proud to lead it here. Thank you.
Okay.
So again, please reminder to put any questions you have in the chat or Q&A function. We do have one question so far. This question reads, Yosef, there is non-compliance with evidence-based guidelines, which is a problem. How do we address that?
Can you hear me?
Yep.
Lack of compliance with evidence is a cultural phenomena. As you could see, what happened in the last couple of years with the average citizen complying with masks or vaccination. Both are evidence-based. And you can imagine if the public doesn't recognize the evidence, what happens in a hospital? Medical staff are also skeptical, especially those who work in an institution or practice medicine for a long time. They tend to rely more on their experience and the experience of their immediate peers rather than peer review articles. What I discovered is that very few people, physicians and individuals who work in quality management understand statistics or can explain or educate physicians about statistics. And this is a crucial area of development, especially today with the availability of data. Quality management must know or must have somebody with expertise in statistics so they can explain the evidence and the resolution of the peer review. So in addition to the statistics, they need to explain and teach physicians and nurses on the methodology of the peer review. I believe that only after they understood the statistics and the methods, they will comply with the evidence. Until then, there will not be a complete compliance with evidence-based medicine. I hope I answered your question.
Gotcha. Another
I
attendee.
would just
Sorry, go
add
ahead.
a little something in, you know, when it comes to evidence-based care and guidelines, I feel that the more we get the teams to use the order sets, the easier it is for the other disciplines to follow the clinical practice guidelines for just different diseases. Sometimes we end up monitoring that through a checklist that we may use for a CMS star condition like pneumonia or heart failure to see if the different interventions were met to prevent the outcome of mortality or readmission. So we do some monitoring on that as well. And our compliance with clinical practice guidelines is pretty high, I think, because they know we are monitoring it. Sometimes the staff, if it comes to like a nursing guideline, have a hard time figuring out which one to pick. But for the most part, I think we reinforce the why we use the ones we use for whatever condition it is. So thank you for that great question. Ready for the next, DJ?
Gotcha. Another attendee writes, I work in the ambulatory setting within an integrated health system. Our senior leadership team holds regular orientation sessions for new team members. What is one message I should focus on with this audience to establish a foundation for building them into our culture of safety?
I'll try to respond to it because it is a complicated answer, because in ambulatory sites, physicians tend to be a little bit more independent because they're far away from the central office. So my method, and I saw it also in Intermountain, is simply to have data, to have dashboards that can illustrate the standard deviation from the mean for a particular evidence. And this is the only way they will understand it. So again, dashboards with statistics explaining the dashboard.
I would add that our role in an orientation is to really have the people learn to put better systems in to establish that culture of safety. And if they understand their sense of purpose and understand the different scope of practice they have and what outcomes they want to achieve, and using those dashboards that Yosef has, that would be the message that I would give in that orientation.
Another attendee would love for you to explain more about how you got others interested in quality teams.
When you say others, you mean other clinicians? Can you repeat the question? Yeah, other clinicians. I want to say ongoing education, but it's really not enough. Myself, I went from one hospital to another in our system, from one clinical department to another, to bring the message of evidence-based medicine, to teach them statistics, to teach them about the validity of a database. And I did it, this was in the last few years, I did it full time. I started in surgery, where I attended their M&M at 7 o'clock in the morning. I convinced the chairman to allow me to talk for 20 to 30 minutes. And then I moved from one department to another, from one hospital to another. It is hard work, but it's worth it, because once the physician, in particular the surgeons, accept your information, accept your data, they will start to measure against it. So for example, we started with cardiac mortality, and by presenting the data, explaining to them the data, they accepted it over time, and they utilized it to measure their performance. And this is really the key, is to change their opinion about statistical information so they can internalize it.
And in building on that, I find that people want to come in to work on quality projects and be part of our department and our structure because they see that we can, building on what Yosef said, influence decisions for the right reason. I also think that here we operationalize quality into what we do. So we're part of all the hospital meetings. It's not a separate function that has their own meetings. So every Thursday in our strategic report out, we report on our progress with quality initiatives, whether it's blood clot prevention or preventing readmission. So I think they see it, the quality process intertwined with operations and our strategy, and that the team is very influential in, our actions and improving systems. So we tend to get applicants to apply to positions here as well.
I'd like to add another comment. The reason that Andrea is so successful is that what you really need, a partnership between the chief medical officer, the chief nursing officer, and quality management. And the whole idea again is to marry clinical information, clinical knowledge, and statistical information to create a phenomena that may be called evidence-based medicine or outcome.
Another attendee writes, having a statistician is so important to obtain reliable data. How does a smaller facility manage to get reliable data?
Again, it's a very good question, and we were really fortunate. Our small hospitals are part of a large network. So we could create an internal benchmark for the system and for the small hospitals by looking at the numerator and denominator for a particular phenomena. So if you look at sepsis, you want to weigh the size of the database or the size of the census as an issue of putting weight in terms of a particular mortality. If you look at sepsis mortality, you want to say that the mortality in a large hospital, the percentages are different. They may be the same as the percentages in the small hospital. However, the weight has to be analyzed in terms of the census, so you can give a fair evaluation on mortality. But again, if you're independent and you're not part of a network, which is very rare, risk adjustment that is typically provided by CMS or the Department of Health in a particular states, they take into account the size of the institution when they develop the risk adjustment. I hope I answered the question.
Yeah, I would recommend sometimes use the hospital association because sometimes they have a great way of displaying data that we didn't even think about. It's not usually as concurrent as we would like, but definitely has the ability to compare for major data sources. So that's one thing. Believe it or not, here at a large tertiary hospital, I still have nursing abstract sepsis data because we don't have that automated. And so we're still doing a lot by hand and trying to teach the analysts the different tools to display the data and analyze it. So it's some things it's easier and other things we're still needing the help as well.
Those seem to be all the questions that we've received so far. Otherwise, or with that said, Andrea and Yosef, thank you again for your time. If you have any closing remarks or final thoughts, please go ahead and provide those. Otherwise, I think Dr. Westphal, you can go ahead and wrap up today's session.
The only thing I want to say is that besides having a wonderful time taping the sessions and being part of these sessions, and I'm glad that physicians are starting to participate in those sessions, we will continue to focus on statistics and data in the next sessions also, because it's the interpretation of clinical phenomena is extremely important. It has an impact on any clinical phenomena that exist in our healthcare, especially today with the COVID that is rampant in every organization. Thank you very much.
Thank you. You're muted.
You're muted.
Oh, sorry about that. Yeah, I wanted to thank you, Yosef and Andrea. I thought it was a very good session. I stayed in tune, even though I've heard a lot of these things before. It's always good to hear it in a different way. And I thought there were some new perspectives that I gained about what you discussed, and I really appreciate it. And I think those of you who participated can certainly appreciate the quality that has gone into these presentations, so to speak. So I just wanted a couple things just to make sure that I remind you to renew your 2022 membership at ACMQ. And then next slide, I would like to have you save the date, September 30th, October 2nd, 2022. We'll be having our annual meeting in Chicago. This will be our first live meeting since we had a meeting several years ago in Maryland. So we hope that all of you will keep that in mind and make plans to attend. Really exciting. We're going to have a really dynamic lineup, and with all of our virtual meetings that we've had, it have been so successful. This will even be more so, I think. So I'll be glad to get back in person, and thank you all for attending. Have a great afternoon.
Thank you. Enjoy Florida.
Now, well, thank you. Thank you very much, Andrea.
Yeah,
Oh, yes.
thank you, Dan.
See ya. Take care.